Good afternoon, everyone. I want to welcome you to the final session of today before our reception. And this is a plenary debate. It is the only debate at this meeting. And it's entitled, well, I'll get to the motion in a minute. I'll first introduce myself. I'm Tom Quinn from Johns Hopkins University and also with the National Institutes of Health. Keith asked me to make one announcement before we get going. Someone has left their reading glasses, and so I'm just going to leave them up here. If anyone knows who's missing their reading glasses, so they're right there. So it's a great pleasure to introduce our two speakers who are going to take on a debate topic that has proven to be very, very important, both from financial as well as policy initiatives. And it's entitled, and I want you to think about this topic, it's entitled Investments in the SDG Framework, Sustainable Development Goal Framework, should be focused on strengthening health systems and not on specific diseases. So that's going to be the motion. I'm going to read that after my introductions, and we're going to do a pre-vote. After the debate, we will then do a final vote as to how we should move this motion forward. So let me introduce our two distinguished debaters who are with us this afternoon. And on my left, your left, is Sandro Galea. Dr. Galea is Dean and Professor of the Boston University School of Public Health. Prior to his appointment here at Boston University, he served as Professor and Chair of the Department of Epidemiology at Columbia University Mailman School of Public Health, where he launched several new educational initiatives, substantially increased the focus on 6 core areas: chronic, infectious, injury, life course, psychiatric, neurological, and social epidemiology. Prior to Columbia, he previously held academic positions at the University of Michigan and at the New York Academy of Medicine. He has published over 500 scientific journals, articles, 50 chapters and commentaries, and authored 9 books. Dr. Galea has a medical degree from the University of Toronto and graduate degrees from Harvard University and Columbia University. He's past president of the Society for Epidemiologic Research and an elected member of the American Epidemiologic Society, and he's a member of the Institute of Medicine of the National Academies of Science. Olusoji Adeyi is the director of the Health, Nutrition, and Population Group Practice at the World Bank Group. He has served for the World Bank Sector Manager for Health, Nutrition, and Population in Eastern and Southern Africa, with responsibility for the institution's support for policies, strategies, and programs in the sub-region. Dr. Adeyi is the founding director of the Affordable Medicines Facility for Malaria at the Global Fund to Fight AIDS, Tuberculosis, and Malaria. He was formerly coordinator of public health programs at the World Bank and has extensive experience in policy, strategies, and programs for health systems, service delivery, and disease control at the global, regional, and country levels throughout Africa, Eastern Europe, and Central Asia. He has also had responsibilities with the Federal Ministry of Health of Nigeria, of the World Health Organization, UNAIDS, Harvard School of Public Health as well. He is, like Dr. Galea, has also authored numerous research papers and books on service delivery, quality of care, maternal health, health financing, HIV/AIDS, tuberculosis, malaria, chronic non-communicable diseases. So please welcome both of our debaters. So it is a real pleasure to have such distinguished individuals taking on this very important topic. Now, let me read the topic, or the motion, once again. And as I do that, think of which side you would like to take if you were sitting up in their place. Investment in the SDG framework should be in strengthening health systems and not on specific diseases. All of those in favor of the motion to, again, focus on strengthening health systems, not the diseases, please raise your hand. 92%. Okay, that leaves a few. There were a few hands not up there. So how many are against the motion? Please raise your hand. You know, I actually guessed pretty good there, about 3-4%. How many are undecided? Come on, there's a few undecideds out there, 1%. Okay, so we have 1% to go. At the end, the interest is to see, does it sway any? Does Sandro pull it all over to his side, or does Soji pull, 4% over to his side, in which case he wins? Okay, so the rules of the debate are that each speaker will be given 7 minutes to make their case. At the end of that, they will then be allowed a rebuttal of 4 minutes each. We will then open it up to all of you to come to the microphones and to make your case. Ask questions, challenge either of the debaters, and then we'll bring it to a close so that you can all enjoy the reception afterwards and continue the debate outside of the room. So without further ado, I'd like to introduce Dr. Galea to the podium.
Thank you, Tom. Thank you, Soji, for doing this together. There should be slides that appear somewhere. Are they appear? Yes, there are. I have made a career out of being the underdog, so I'm very uncomfortable with having the room already on my side. I feel like I can only screw it up from here, so I should probably just step down and not even try to make the case. So how do I move the slides? Does this work? Let's assume this does. Okay. So yes, it does. So this is the motion that Tom already read, and I put it up because I'm in favor of the motion and I like the way it reads. And in the interest of parsimony, end of the day, debate, and all that, I really only have 3 reasons for this, and I want to lead you through what those 3 reasons are. And as I think you'll see, they conform with what I think many of you have been thinking about in the room. And the 3 reasons are as follows. One of them is about ownership, intent of the SDGs, the other one is about epidemiology, and the other one is about sustainability. So starting with ownership and intent of the SDGs. This is from the official document that establishes the SDGs. SDGs are intended to be universally applicable to all countries, but take into account national realities, that's fine. But they're supposed to take into account capacities, levels of development, and respect national policies and priorities. The notion behind the SDGs is that they're development goals that are ultimately sustainable, that are owned by the countries. And it is, in many respects, the exact opposite of the entire field of development and vertical programs to move towards development goals that are sustainable this way, that are sustainably owned by the country. The SDGs are definitionally focused on building approaches that are sustainable. We cannot do this by vertical approaches alone. And ultimately, we cannot replicate programs over and over again in country after country. So it strikes me that it is the ethos of the SDGs, in many respects, why the SDGs were started, to create development goals that are sustainable, that are country-owned, that respect national priorities. And the only way to do that is to build national systems that can improve health in those countries. Vertical programs do exactly the opposite of that. They ultimately are programs that are brought in by outsiders, be they country or be they bilateral organizations, and implement programs targeted at specific outcomes. Those outcomes, not, I wouldn't say typically, I'll say not unusually, driven by external determination of what the key priorities are, in contrast with a set of sustainable development goals that aim to build local systems that aim to create sustainable local capacity to deal with health priorities as determined by local governments. So in many respects, the motion says, well, the Sustainable Development Goals should be the Sustainable Development Goals, which is one reason why I think the motion is valid. Second reason, epidemiology and temporal trends. The world of global health and development is, like many other worlds, both in terms of implementation science as well as scholarship, developed, of course, through a history that reflected the key priorities of the time. And much of global health, as everybody in this room knows, emerged from the world of international health, and much of that world emerged from the world of tropical medicine and tropical hygiene. That was a world of simple diseases. There was a world of simple diseases, simple infections, simple bugs, which could be treated by vertical programs that target particular outcomes, target particular exposures, that if we did something about them, we are going to eradicate and move on. Of course, the world is changing. That is not the world we're in right now. This is a non-communicable disease. Everybody here knows that this is not the next epidemic, it's the current epidemic. There are endless sessions at this meeting about non-communicable diseases. And what we also all know is that non-communicable diseases are complex. We are not going to find a single gene that fixes non-communicable diseases, despite what the National Institutes of Health may think. We are not going to have a single pill that deals with non-communicable diseases. And no matter how much we have programs that are well-intentioned that aim to modify people's behavior singly down a particular path, we are not going to achieve meaningful reduction in non-communicable diseases. These are complex diseases that require complex approaches that must be nested within sustainable systems. And I mean, that's looking forward, but just looking at the MDGs, there's ample evidence. This is exactly how the world works. What you have here is the child health and the maternal health MDGs. On the left, you have child health, you have infant mortality. On the right, you have maternal mortality. And you see that we have achieved success in the MDGs on the health indicators that are straightforward, for which there are simple, single interventions that can be effectively implemented through vertical programs, as there is in many cases with infant mortality. Not so at all with outcomes like maternal mortality, which are complex disorders that require system-wide efforts. Many efforts like the Merck for Mother efforts that is trying to make a real dent in maternal mortality. These are system-wide efforts that are trying to scale complex interventions across entire systems. And even where system-wide efforts do make a dent in the context of complex disorders, you actually have progress for some, stagnation for others, and things get worse for some. This is a breakdown of maternal mortality. When you have, on the left, you have high maternal mortality countries. On the right, you have mid-level maternal mortality countries. And you see some countries go up, some countries go down. In other words, we are failing to achieve uniform reduction and progress towards that particular goal. So that's the second reason. Third reason is sustainability itself. These are ultimately sustainable development goals. They're intended to be sustainable. They're intended to move development to its next phase of, as I said before, country ownership, country accountability, building country-level systems that improve the health of populations. And there are many reasons to believe that absent system-wide efforts, any development effort that's intended to improve health is going to fail, at least in the long term, or even if it succeeds, it is going to succeed for particular groups, leaving health inequalities untouched or even worsening health inequalities. So this is a slide that looks at multiple coverages for pneumonia, oral hydration therapy, etc. And the dots are look at quintiles, at essentially wealth quintiles. And all I want you to see here is that while coverage, which is on the x-axis, varies for multiple indicators, for all indicators, there is tremendous spread across wealth quintiles. And this is what happens when we try to achieve rapid wins with unsustainable approaches. That at the end of the day, vertical programs, despite our best efforts, create the perverse incentive to make sure that we achieve success among a select group. And that group is always, always, always the rich, relatively speaking, in different contexts. It reifies the accumulated resources of the rich, the powerful, the well-connected within groups. So even if we thought that, look, we can do this vertical program thing, we're going to achieve some outcomes. Yes, we are going to achieve some outcomes, but we are worsening other aspects of health. And ultimately, we all know that inequalities in health and in other resources are, in the arc of time, unsustainable. Whether the arc of time is 1 year or 5 years or 10 years or 20 years, we know that this is ultimately unsustainable. And there are also substantial downstream costs of non-functioning health systems that also point to the unsustainability of vertical approaches to promoting these SDGs. For example, absent functioning cell systems, we know that there are about 100 million people who are impoverished by paying for health worldwide. In a study that we did, we found that in 40 low and middle income countries, 30% of people, that's 1 in 3 people, which is quite extraordinarily high, sold assets and borrowed to pay for health. And just to be entirely clear, since this meeting is being held in the US, the US is a lovely example of this because the US is a classic country where there is no health system. So one might ask, well, how are we, so what's happening in the US? Well, here's the US. This is a paper that shows when you look at causes of bankruptcy in this country, 2/3 of causes of bankruptcy in the best study I know of on this are actually caused by medical reasons. This is what happens when you don't have health systems. This is why if one seriously cares about having development goals that are, forget sustainable, if one cares about development goals that actually achieve anything, they need to be based on systems. If they want to be sustainable, it is paradigmatic that they have to be based on systems. And you shouldn't take my word for it. There are many people who have said this. It's from Institute of Medicine report, which ultimately says health system limitations are the binding constraint preventing further progress in global health, to which I say, exactly. And the Lancet Commission 2035 report, which many of you in the room were on, they obviously had a very hopeful aspirational message that a grand convergence is achievable within our lifetime by 2035. But, I mean, that's the line that everybody quotes. But you should actually read further. It says it is achievable assuming that you have coverage levels of at least 90%. And all their modeling is assuming a coverage level that's at least 90%. Coverage levels of at least 90% suggest the need for a health system. So I will go back to my, this is what we started with, and I say yes. That's it. Thank you.
Adeyi, you may take the podium at this point. Now, please welcome Dr. Adeyi. I also will accord you 2 extra minutes since Dr. Galea went 2 minutes over.
Thank you. First, true confession, I did try to unplug the mic while Sandro was speaking. It didn't quite work, so I have to try something else. It's good to be here, home of the Boston Tea Party. I understand that this city has a tradition of participatory approach to development, and that was the origin of the Tea Party. So let's start on a participatory approach. Everybody here who owns a smartphone, please raise up your hands. Very good, thank you. Everybody here who understands all the fine details of how the smartphone works, please raise up your hands. Thank you very much. I submit to you there's only one rational reason for making any investment. You want a return on your investment. And the return you get on your investment in that smartphone is that it works for you. Does it tell me the time? Can I make a phone call on it? Does the app work? The only folks in your household who understand the intricacies and who bother about the intricacies of the system, of how it works, are either the geeks in your family, or your teenagers, or both. Right? Very good. Next participatory experiment. All those who have ever driven a car in this room, raise up your hands. Thank you. All those who understand all the fine details of the internal combustion engine and the electronics of the cars, raise up your hands. Thank you. The only reason you invest in it, you want a return on your investment. It takes you from point A to point B. Now, what has that got to do with health? Let's go outside this room and reflect on a few things in the past. This first one here is what smallpox used to look like. Okay? And it's not a very pretty picture. Now, what is the public in public health? We're talking about things that have externalities. We're talking about global public goods. So in fact, it is not only the wealthy people who have benefited from the eradication of smallpox. The poor people have too. And in this country where we stand, the United States, I understand, saves every 26 days exactly what it invested in the eradication of smallpox. So I have a deal for you. If you give me $100 today, I'll give you $100 every 26 days. Great return on your investment. Let's go to another continent. You've probably seen this photo before if you haven't seen the statue. That is a boy leading a blind man. As a result of the tremendous investments in the Onchocerciasis Control Program and subsequently the Africa Program for Onchocerciasis Control, generous donations from Merck, a lot of work by the local communities themselves, tremendous gains have been made against river blindness, and it goes beyond the individuals. Millions of hectares of arable land have now been freed up for productive cultivation with the potential to feed millions of people. Friends, they work. This is not a question of vertical, this is not a question of horizontal, it is a question of does it work? Do you get a return on your investment? You do. Now I submit to you that developing a system is not an end in itself. It's not a goal. It is only a means to an end. And if you don't specify your goal in terms of a concrete achievable outcome, you'll be going around in circles until the second coming of Christ or Muhammad, and you will not get your return. It gets even better. You remember the March of Dimes? President Franklin Roosevelt actually had polio. And in this country, there used to be lots of iron lungs. And folks who look like this girl. It's mostly history now in this country. It's history. And there are only 3 countries where it is still a big problem: Afghanistan, Pakistan, and Nigeria. Because there was a goal, a clear goal, and the system for achieving it was just a means to an end. Of course, we have the demographic transitions and we have the epidemiologic transitions. So much for the past and the present. What about the future? I know that in some places in this country, evolution is banned. You cannot teach it in schools. That's very good for those students. It reduces the homework. But in those places where the teaching of evolution is not banned, this is probably all they need to know. This is all evolution is about. And of course, it means that we now face a pandemic, if you like, of chronic non-communicable diseases. What ties all of this together? There is a myth out there that you have, on the one hand, standalone vertical programs that are bad, and on the other hand, you have beautiful horizontal programs that work on systems that are inherently good. And it has become an article of faith in some places, as if these things actually came from the laws of Hammurabi. So some years ago, Rifat Atun and I, Rifat used to be at Imperial College, is now at Harvard School of Public Health here, together with a few folks, decided to do what we call clearing the global health fog. We actually did a systematic review of the evidence on the integration of categorical or vertical programs into health systems. And lo and behold, we found that the evidence was as thick as this. There were hardly any purely integrated programs, and there were hardly any pure standalone programs. The 2 most useful words we found in the English language were, "it depends." It depends on what you're trying to achieve. So one of the surest ways of shortchanging the next generation is for us to focus in a cherry consensus, such as the cherry consensus that happened in this room about 10 minutes ago before my dear friend started to speak, is to focus a cherry consensus of the goals of the SDGs on quote-unquote systems. Because it means we don't know where we're going. And if we don't know where we're going, any road will get us there. So I challenge you, just like you expect something concrete of your cell phone, and just like you expect your car to take you from point A to point B, and just like we now celebrate and benefit from the gains of smallpox eradication and the elimination of polio from most countries, and the continuing gains against river blindness, that the goals in health of the sustainable, the SDG goals that have to do with health be focused like laser beams on specific diseases and specific conditions, and that the development of systems be means to an end. We'll go even further. All those who believe in accountability, raise up your hands. Good, very good. So we take it even further. We all believe in better health outcomes, and we believe in equity, and we believe in efficiency. So all those in this room today, and all those who work at WHO and UNICEF and the World Bank, will say, sequentially, that our remuneration be tied explicitly to independently verifiable improvements in health outcomes and the efficiency and equity with which they are achieved. That will really call our collective bluff, because we will not be able to hide behind the euphemism of strengthening health systems. We will be able to pin ourselves down on the extent to which we've been able to work with communities, we've been able to work with countries to actually improve gains in health, not the number of conferences that we hold to talk about health systems, not the number of measurements that we turn up on health systems, but the extent to which those health systems have resulted in measurable improvements in health outcomes. Now, just one quick reflection. May I remind us? The outcome document of the UN Conference on Sustainable Development had 4 magical words in it. The future we want. That should be the focus. The future we want. And unless we pin that down in specific terms, quantifiable terms, we will be shortchanging the future generation. Besides, in terms of sustainability, sustainability compared to what? If ownership is key, then obviously it means the politicians, the policymakers, the parliamentarians in every country around the world need to be accountable to the population that they serve. Otherwise, there will be no ownership there, and otherwise, it will not be sustainable. Whatever gains we make will not be sustainable. It's very hard for Jane Doe and John Doe in Nicaragua and India and Montana and Kenya to get excited about and hold their parliamentarians accountable for some nebulous thing called health system strengthening. But boy, they recognize when people die of certain diseases, they recognize when there are complications from poor treatment, and that should be the currency of the realm. Now, I'm not going to hold against my opponent the fact that he's on home territory. That would be entirely unfair. Right? So out of that act of great generosity as his guest in Boston, I'm going to concede that it's perfectly understandable that folks started out here feeling very strongly that the focus on the investment in the SDGs should be focused on health systems. It's understandable. I only ask you to reflect very carefully on what it means if, for example, we invest in systems that are not designed to go very far. And you don't have to look very far to find an example of such a system, because as we travel around the world, I have a colleague who, if he's ever asked what kind of advice he has to give, he says, well, I really cannot tell you what kind of health system to invest in, but I can tell you what kind of health system to not invest in. And when they asked him what, he said, well, do not try to copy the US health system. But there's a rider there. The US health system actually makes perfect sense in terms of the narrative of the society. It's everybody for himself, God for us all, and may the devil take the last person. So the US health system is actually is delivering exactly what it was designed to achieve. It's highly inequitable, spent a lot of money but does not achieve what lots of other OECD countries achieve. If you don't want to end up with this kind of scenario in many other countries across the world, we better be very explicit in terms of the goals we want to achieve, so that the health system will be forced and designed in a way that achieves those goals. Thank you very much.
Sandro, your rebuttal.
Thank you, Soji. So my analysis of my opponent's comments are that he had 4 points. I think he's wrong on all 4. So let me tell you why. But I think he was right in his conclusion, as I'll tell you in a second. Number 1, we heard that one of the arguments in favor of vertical programs is that they have worked in the past. There's no disagreement. The examples that were shown are river blindness, smallpox, and polio. I conceded in my comments that it has worked in the past with simple problems, with simple solutions. I argue that that is not relevant to the current discussion, because the current discussion is about the future, where we're going to have complex problems which require complex solutions. That's point 1. Point 2 was, not only has it worked, that one needs to be skeptical about systems efforts because they may not work, or comma, other vertical programs might also work. So I would challenge the audience with their smartphones. I know you don't know how they work, but that was a good point, by the way. I like that. To go onto PubMed, not when I'm talking, when my opponent's talking, and look up published evidence of vertical programs that showed no effect. And then look up published evidence of vertical programs that showed that they work. I guarantee you that the balance of papers in PubMed is about 1,000,000 to 1. So because we want to believe these things work, we invest billions of dollars in vertical programs, and we don't like admitting that they don't work. Who's we? Everybody is guilty. Academics don't like it. Department chairs and deans don't want to promote people who don't show things work. Funders hate it. So we actually think that these programs work because we publish that they work. We set ourselves low bars, and we keep telling ourselves these vertical programs work, therefore other approaches, horizontal approaches, systems-based approaches, may not work, and we already have a way that works. Let's stick with that. I think we are wrong. We actually have a number of programs that in fact don't work, and we've been kidding ourselves. So continuing on this path is really continuing down a path that we think is successful. Yes, it's been successful in a couple of infectious diseases, but broadly it has not been successful. That's number 2. Number 3, the point about return on investment. I thought it was a very interesting point that says, well, we should do what works. Now, I've argued that actually what we think works doesn't necessarily work because we get return on investment. So return on investment is a really interesting concept. It is on my list of papers to write about a notion about return on investment in population health. Because return on investment, of course, is what you want it to be. And we frequently think on return on investment in the short term and think that once we stop applying our lens, the return is going to continue. In fact, there is ample evidence, although not much of it well documented, that when we think about return on investment, we are also kidding ourselves because the return we are seeing is short-term and unsustainable. And if one does population-based return on investment analyses, many of our development efforts would fail miserably. So the argument is, do we want return on investment? Absolutely. Are we getting return on investment right now? Probably not very much. We need to not say we're going to stick with what we think works because it worked in the past, which, by the way, doesn't really work and it worked only in a limited way in the past, but reconceive how we make an argument for return on investment and make it clear that we expect return on investment in the long term to truly create healthy populations, healthy whole populations. That's the third point. The fourth point is, which it was a really nice turn of phrase, around the euphemism of systems-based approaches. And the point, if I understood it correctly, was that saying that we are taking systems-based approaches gives governments and donors and all of us the excuse to muddle around and not do anything which has measurable outcomes and say that we've achieved success and join forces and sing happy songs without actually doing anything. I think that is a very important point, but I would argue that that is the challenge to which we should rise. It should be unacceptable for us to euphemistically label programs and expect them to succeed and say they're succeeding when in fact they are not. And I argue that there is a chance that we do that. That is a mistake we can make as long as in this room we do not have 100% of us recognizing that the ultimate goal is to improve, strengthen, and build robust systems owned by countries that can achieve real return on investment in the long term, that really work rather than we think they work, for complex diseases for which they work. The last point was about the SDG line, which is about the future we want. I couldn't agree more. So the question really is simple. Do we want a future? Do we want a future that is today? Today is a system where there are extraordinary, deeply unacceptable inequalities in health across countries. That is essentially the underlying ethos why this meeting even exists. That is exactly why the entire global health development enterprise exists. It's because there are health inequalities across countries and within countries, but just sticking across countries. So therefore, an entire industry, which a lot of us are a part of, has developed to take resources from one place, to put them in another place, to try to fix that place on something in the short term, and then, wait, that place doesn't do so well on something else, let's take resource from here to put it there, and then move it from here to there, in this never-ending vertical program match of trying to catch up with the hottest disease of the day. That is today. Is that the future we want? I would argue that's not the future we want. The future we want is a future where the health of populations is an integral part of the value system and of the ethos of all countries of the world, where we achieve a Rawlsian ideal where all individuals are born with the capacity to achieve fully their potential based on how much they want to work, not limited by health and disease, and the only way to do that is by having sustainable health systems in all these countries so that everybody can achieve that. That's it. Thank you.
Sochi, it is time for your rebuttal.
I must have been very bad in my former life. To be condemned to constantly speak after Sandro. So the penance continues. We're no more than perhaps a couple of miles from the greatest cathedral in Boston. It's called Fenway Park, where the faithful go to worship. Now, I come from a place where they don't play baseball. But what I really, really appreciate about baseball, they keep score. They keep score. They have a lot to teach the global health fraternity and sorority. What's your batting average? How many home runs did you hit? Did you make it to the World Series? Did you win? Did you lose? And you don't even have to hit a home run all the time. Gee, you don't even have to hit the ball all the time. I understand that in baseball, if you hit 1 in 3, you're going to the Hall of Fame. 1 in 3. Not bad. That's the reason they keep scores in baseball. That's the reason they keep scores in basketball. How many points? How many assists? That's the reason they keep scores in soccer. How many people here ever watch the World Cup series in soccer? Football, the one you play with your feet, the real football. Very good. So you probably remember, my good friend Charles is here, Charles Larson. We go way back to the early 90s, late 80s in Ethiopia. So he'll remember this. There was a particular occasion where the Brazilian team included Zico and Socrates, etc. I'm really carbon dating myself now. And they were so good, Time magazine carried a story that said, only God can stop Brazil. Then they played the Italians, and they lost. So somebody interviewed the Italian coach later, and he said, I'm paraphrasing, he said, oh, the Brazilians, they played beautifully. They were dancing around the midfield. And they forgot that in football, i.e. soccer, you score goals at the end. I submit to you, ladies and gentlemen, that the Brazilians had a disease I will call systemitis. And that is what my dear friend is telling to you. And I'm saying, let's turn to the Italian way. You want to score goals. Now, the system you use to get there should be flexible. How you get there is up to you. But the Italians won the World Cup. Why? They developed a system that was fit for purpose. But how do you know your system is fit if you don't specify your purpose? You won't know. So it brings us back to the tried and tested idea of your return on investment. If we're going to make the best use of the next 30 years, if we're going to achieve this grand convergence, if we are going to achieve better health, if the future is going to be as bright and even far brighter than what we've experienced in the past 30 years, the focus of investment in the SDGs must be on specific health conditions, on specific diseases, on specific desirable outcomes. And then we'll hold everybody accountable and unleash the ingenuity to figure out what systems are required to get there. Otherwise, we shall be running around in circles. Now, my learned friend referred very rightly to some of the things we see in journals. We see a lot of publication bias. I submit to you that if you did a PubMed search of how many investments in quote-unquote systems have had consequential and positive outcomes, you'll be hard-pressed to find many. And that is just the stone-cold truth. Now think of it, those of you who are in this room. Just look at it through the eyes of the countries for a moment. In how many places have you had development assistance focusing on, we're going to do technical assistance to improve the system? And they come in waves of 3-year projects. They all have fancy names. It's very good business for those who are giving the technical assistance. I'm not sure it's great business for those who are receiving it. How many workshops have been held? How many rounds of data for decision-making have been held? And what have been the outcomes? You be the judge. Thank you.
Okay, so this now opens it up to the audience. So there's microphones all over. You're welcome to ask questions, add your own opinion, and I'm sure this group's got some opinion. Any comments? So we have our first audience participant.
I really enjoyed this debate, and thank you to both of you.
Can we turn the microphone on? Go, give it a try. So,
You're a very friendly debater.
she now has to vote for him. Yeah.
And yet I'm not moved. I do appreciate the gesture, but I'm definitely a systems person, have always been and always will be, even though I really enjoyed both of your points of view. And I do appreciate the points you've made about the nebulousness of the system approach. And I think we suffer from that. The fact that we sometimes miss out on having specific goals and targets, I think is one of the weakness of the health systems approach. However, I would like to point out, maybe for your consideration, what are your thoughts about the Ebola outbreak and what we've learned about vertical systems? And number two, the health workforce shortage in low and middle income countries, which is a very dire problem. How do you view that vis-a-vis your point of view about the vertical problems being more of an urgency for us to pursue? Thank you.
Thank you. You go? Yeah, right. Please. Thanks. With the permission of the systems lady, I would like to remain seated for this particular iteration. We learned many lessons, well, or shall I say, we are learning many lessons from the Ebola outbreak in several countries in Africa. My interim perspective is the following. We're looking at the consequences of multiple failures. Okay? A failure to develop some of the fundamental infrastructure, a failure to develop as much as should have been done, human resource capacity, functions, and also perhaps what I might call a more proactive approach to solving problems. So if you look at it through the way societies make decisions, or the way societies don't make decisions, allowing also for the fact that not making a decision is a decision in itself, then you might say that with the benefit of hindsight, had there been a clear-cut goal that says within so many days or so many hours, an outbreak has to be detected and has to be reported and has to be acted upon, the story might have been different. Why? You'll have set a goal at the policy level, and therefore actions will have been nudged in the direction of achieving that goal. Even if that goal is not, even if that goal is in the form of preventing some things from happening, but that was never there. And I think that is the big lesson that we're learning here. There's a corollary to this that you see in industrial production, okay? Excuse me. Which is trying to catch problems at a very early stage before they explode. So if you were manufacturing Hondas or if you were manufacturing Toyotas, they don't make cars in Boston, right? So I'm not being rude.
No, you're okay.
Okay, good,
Yeah.
good.
Just don't bring up tea.
Okay, I will not say the T word. So if you are manufacturing Chevrolet or Honda or Toyota, you really want to catch your defect very early before they explode, before your car goes out, it goes into the population, and you have to do a recall. And if you look at it through that lens, it's almost a case of an automobile manufacturer that got very sloppy, did not catch those defects, they went out in the population, and now you have a mess on your hands. It's, of course, a lot more explosive than that because you have the spread of a global public bad. And in addition to that, there wasn't just the epidemic of a viral disease, there was also an epidemic of fear, which is what led to the economic problems. It wasn't just the number of cases per se, it was epidemic of what you might call irrational fear. I mean, Korean Airlines stopped flying to Nairobi. Last time I checked, Nairobi was thousands of kilometers from Liberia. It just made absolutely no sense, but it was part of the panic that went on. Thanks.
We have a question over here on the right.
Yes, Oliver Fine from Cornell in Manhattan. I was surprised that the panel didn't bring up a question about, is there a way in which vertical programs undermine system building? And one example that has occurred to me is that some vertical programs, when in fact they are based in a developing country, end up paying the local population of providers, physicians, nurses, and so on, more than in fact the public health departments of those countries. And the result is that in fact the system is, in some ways undermined by the vertical program. I'm interested in whether the panel feels that does happen and how that influences your position.
We'll have both of them reply.
So I actually cannot see Dr. Fine, which is, feels rude. I apologize. There you are. So I'm glad you made my point for me. Thank you. So while my esteemed opponent was speaking, I was bursting out of my skin to make the point. I actually do not think it is cost-free for us to accept the flawed notion that vertical programs may be the way to go. I think the logic is incontrovertible and overwhelming that systems approaches is the way to go towards achieving sustainable development goals. And if we allow doubt in this community's mind, those 5 or 6% of you who are thinking of voting against systems, it's in your hands. Because if you go that direction, we are allowing the overwhelming forces of the present the room to wiggle their way into dominating the future. There was a comment that the science around systems efforts and their outcomes remains weak. I couldn't agree more. But the reason for that is that trying to grow the science of systems improvement is like trying to grow a sunflower in a bed of that's normally made for pansies. We do not have the funding, the intellectual focus, the body of people in this community who are investing all their time in systems that will allow us to move that scholarship and that practice forward. So I think there is a real cost. You mentioned the human costs on the ground, which, by the way, I think is inarguable. I'm not even touching that. I think there is a real cost to not moving at this point in time in 2015 as a big tidal wave in the direction of saying this is the right thing to do and this is what we should be doing. And when one makes the mistake of thinking that the current metric still works, it doesn't allow us to see things that are obvious. So if I may just, I now feel strongly that not only must I win this debate overwhelmingly, my esteemed colleague raised the bar by challenging me to a football metaphor off. So I feel like I must take that on, if you may, if you allow me. So my colleague brought up the best football game in World Cup history ever, which was the 1982 Brazil-Italy game. For those of you who haven't seen it, stop listening now, go outside, you can find it on the web and watch it. But I will actually use a different game to illustrate the point made by Professor Fine around the consequences that it's not cost-free to think wrongly. And I will make that point by commenting on probably the most notable public statistical analyst of our time, who is the American Nate Silver, achieved great fame by predicting elections. Nate Silver achieved fame and money by essentially having this simple idea, brilliant really, saying, I don't need to invest money to run polls to figure out how people vote in elections. I'll just take your poll and your poll and your poll, put them together, average them, weight them out, and look, that's better than everybody else. I can predict all elections. He did that. And the genius to Nate Silver's method was that he could predict population effects, but he was swayed by the dominant American cultural ethos towards understanding individual behavior. So he went into the business of predicting football games, soccer games, for those of you who are not with me, football games. And in the last World Cup, Nate Silver said that there was a 72% chance that in the semifinal game between Brazil and Germany, Brazil is going to beat Germany. But wait, he said, my methods are very sophisticated. Neymar, who was Brazil's star, might be injured. Therefore, I have accounted for even Neymar's leg, and if Neymar's leg is not working, there's a 63% chance that Brazil will beat Germany. Now that is pretty astonishing, great accuracy. Of course, for those of you who were asleep for the past 2 years, Germany destroyed Brazil 7-1. So the point is that it is not cost-free to think wrongly. Nate Silver made the mistake of accepting dominant ethos that said, we can do these prediction things at the individual level. In fact, it's wrong. We are terrible at individual prediction. We're good at population prediction. It is similarly wrong to think that we're going to succeed with vertical programs, and if we keep thinking that way, we're going to make mistakes about not fully embracing systems-based approaches, which is where we should be headed.
I love this game. Now, let's reflect on what happens if and where an externally funded program goes into a country and the remuneration is higher than the baseline remuneration in the public sector when a program started. Underlying that question is an assumption that the pre-existing level of remuneration was quote-unquote right. And I will invite us to think that through carefully. Is it? It just happened to be what it was. There was absolutely no science underpinning the previous level of $100, $5,000, $2 per month before the externally funded program got in. It just happened to be what existed. Secondly, there's another assumption there, which is that public worker, the public sector worker, did only that job, took only that income, and never did moonlighting anywhere else. And that was the person's total income. So in fact, it just might have been that before the externally funded program came, that public sector worker earned X dollars per month and was probably present 100% of the time, but perhaps was not present 100% of the time. So in fact, it doesn't stand to reason that the externally funded program introduced a distortion. You probably had, the system was not at an equilibrium before the externally funded program came in. It was just that the externally funded program revealed the prior lack of a functional equilibrium within the public system itself. And it leads to another question. What then are some of the public policy implications of the adequacy of supply of workers, of the adequacy of remuneration of workers, and of course, the labor market itself in its entirety? Now, for those of you who love listening to public radio, I think very highly of my good friend, Mr. David Brooks. And he philosophizes a lot, like most other pundits did before the last elections, okay? Now, one of my hopes, of course, is that while 97% of you were misguidedly supporting my learned friend's point of view at the beginning, that I can bring that number down to just 47%, okay? And I'm making no connection between that 47% and the election 47, so don't think so, okay? But something interesting happened. Mr. Brooks had no evidence. He had no data to back all the philosophizing he was presenting on Shields and Brooks, okay? And they were saying, oh, the election is too close to call and this and that. Well, Mr. Silva crunched some numbers and said, folks, this election is over. There's nothing to call here. And he got called names, by the way. So my learned friend just admitted to you that the science behind quote-unquote systemitis is paper thin. He admitted to you. Now, remember, you are the consortium of universities in global health. You are hard-nosed, evidence-based folks. You don't make faith-based investments. And my learned friend is asking you to make a faith-based investment. So I'm trusting that being hard-nosed, data-driven, evidence-based folks, you very politely give him no more than the 47%. Thanks.
You can maybe try it later. He does, but we are getting late. We're going to do a vote soon. So very short questions. I'm going to ask both of you very short response. No more football, no more baseball, voting and all that. Very short, and then we're over. Go ahead, Judy.
All right, Judy Wasserheit, University of Washington. So I'm one of the 3 or 4%. So I'm on your team here. And the reason that I voted that way was because a very wise colleague of mine, who happens to be sitting over there stroking his chin, named Jaime Sepulveda, once, oh, what's up? This is good. Once talked to me about working on the diagonal. And I think that's a very important concept. And Jaime, I don't know if you want to say anything about it, but I would suggest to you two that actually the way we need to approach the SDGs is to work on the diagonal, not vertical, not integrated health systems, but on the diagonal. And I'd like your response to that. And Jaime, I don't know if you want to say anything, but.
All right, I'm actually going to hold that for a minute. You guys can remember diagonal, right? Right? I know you both want to say, but just because it is late, I'm going to just have you raise your question, and that's it. And then we'll let you two do a closing.
Actually, in honor of being in Boston, I just wanted to bring up the analogy.
A little louder.
How about now? Okay. So I really quickly just wanted to make a quick comment about, I feel like I hear two different things. I hear the future that we want, the future that we idealize, that we want to transform into, and the current reality that we live in with getting people to change behavior and political will to accomplish concrete goals. And I know you said no more baseball comments, but we are in Boston, home of the Red Sox. And I don't know if you've seen the movie Moneyball, where specifically in the movie Moneyball, they did a paradigm shift. Before Moneyball, before there was this theory that that a team was built around a superstar. It was built around Barry Bonds or someone who could hit home runs, like Babe Ruth. And those are very like vertical programs. You pay a lot of money for one person to hit a lot of home runs. What Moneyball did was change that paradigm. It took the team that was the most unequal out of all the teams. They had a third of the budget of the Yankees, who won all the time. And it took them from a team losing every year to the national championship, or the world championship. Now, they didn't win the world championship, but it actually got them to the game because they changed the system. Instead of focusing on a vertical approach with a Barry Bonds type, they traded away all their big players, and they brought in people who could actually get the job done. And when that paradigm shift happened, the Boston Red Sox, who had not won a world championship since the 1920s, took that approach, and in 2004, they won the world championship. And so they took a system that had a vertical approach, and they shifted the paradigm to actually see how transforming the system and getting the right players on the field could do that. And I think in the same way, we're faced with that same paradigm in global health. So that was just the comment I wanted to make.
Very good. Over here.
Thank you. My name is Ruiwat from Maidon University, Thailand. What I heard from Professor Galea was about the debate on health system and vertical program, which is not the point, because it should not be like all the disease-specific problems considered to be vertical program. That is not right. So it should be like, because the topic is health system vs specific diseases. But specific diseases can be solved by many ways, not vertical program. So to consider, comparing health system and vertical program is unfair. Like HIV, the way to work with HIV is an integrated health system approach for the specific disease program. So in other words, I think that we should have some target, some specific disease, but use health system as a means to reach the target. So I support Professor Soji. Thank you very much.
I agree with you already.
Yeah, he agrees. Okay, the very last comment from the audience, then I'll let each of you have 1 minute closing.
Yeah, this is Jenny Chondo from the University of Rwanda School of Public Health. Mine is just very short. I think we should step back a bit and ask ourselves, what is the problem that we want to solve? And I agree with the Dean of School of Boston University, I guess, on the integration. So even Global Fund, where we had very vertical programs, we ended up creating the infrastructure, paying the lab, which was not part of this, and so forth. So my question is actually to the moderator. Should we talk about sustainable development goals, or should we talk about sustainable and integrated development goals? Thank you.
Okay, so I'll answer that very quickly. That's a very good comment. I would go along with that, but unfortunately, the United Nations, Rio 20, a number of groups have gone with the Sustainable Development Goals. I like integrated goals. I would agree with you, and we can advocate for that kind of change. All right, 1 minute for each one.
The honorable gentleman.
You go first.
This is my esteemed opponent is playing chess with the last comments. I am going to pander, and I am going to tell you why we should nudge the 92% in favor to 97% in favor. I will concede 3% of people who are sleeping. There are 3 reasons, all arising from the last set of very good comments, why the answer is obviously in favor of the resolution. Number 1, with thanks to the colleague who brought up another sport metaphor, the evidence in sport, in football and in other lesser sports, is overwhelming in favor of systems. The only way teams in team sports succeed when they focus on individuals is if they have overwhelming resources. So a case in point would be, for example, Barcelona soccer team. They win year after year because they have 4 times more money than any other team in La Liga. But I will point out that the team that won La Liga last year was Atletico Madrid with 4 times less money because they had a system. We keep making the mistake and thinking that investment in individual programs or individual stars will work because we think we have limitless resources. We do not. So that's point 1. Point 2, the point about the diagonal. I think a vote for diagonal is a vote for systems. Why is that? I believe the rules are that Dr. Wasserheit now cannot reply. But let me tell you why. The dominant paradigm is one of vertical programs, disease-based programs. Once you accept that we should be on the diagonal, it means you are introducing horizontal programs or systems-based approaches, which means you must be conceding that systems need to be a part of it, and you must be conceding that looking forward, we need to get the horizontal in there, get the systems in there, which means diagonal equals systems. Point 2. Point 3. And this point I will build on a comment from my esteemed co-debater, where he appealed to you as the Consortium of Universities of Global Health and saying you surely are for data. Of course you are for data, but you are the intellectual cream of the crop in global health. This is where paradigms shift. Paradigms shift here. There is no question that the dominant, overwhelmingly dominant paradigm today is disease-based approaches. You are here today to say that that's wrong. We should look to the future, to use my colleague's words, through a systems-based approach. If no one shifts paradigms, who will but you? It is exactly why this organization exists. It exists so that you can vote yes.
One of the things I love the most about this opportunity to learn from my esteemed colleague is that he reminds me of the elections of 2000. And so by trying to co-opt the diagonal, I just see these images of hanging chads. So I would say hanging chads don't count. Okay? Now we start counting my 60 seconds. It was 1 minute, right?
Go ahead.
Okay, thank you very much.
He took 3 points.
It took 3 points. Oh, okay, good. So I get 180 seconds. I think a lot of this depends on what the global health community would like to be held accountable for. If the global health community would like to be held accountable for independently verifiable changes, that is, improvements in coverage with high-quality health services, verifiable changes in health outcomes, verifiable changes in the equity with which those goals are achieved, then the case is clear. I ask you to look within. If you are investing your own hard-earned money, will you invest with an investor who tells you, listen, I guarantee you at least X% return, and if that doesn't happen, you get all your money back and I pay a penalty? Or will you go with an investment advisor who says, well, do I have a deal for you? I have these magical things, I'm going to put it in, I have tremendous systems to do it, but I don't know how it's going to come out. Well, I'm that first investment advisor. If you put your money with my investment firm, you're guaranteed some returns like you've seen with smallpox, with river blindness, with polio, for example. If you go with my colleague, there goes your retirement. Thank you.
Outstanding presentations for both of them. Just wonderful. I've been given the high sign that the refreshments are waiting outside. I know this debate will continue on the outside, but I will do the final motion and release you for the evening. Investments in the SDG framework should be in strengthening health systems, not specific diseases. All those in favor of that motion, raise your hand. Wow. All those against that motion? Actually, I think he got an extra 2%. He did. Really? Thank you very much. Have a great evening.